setting all of this up. I've seen so many of you over the last 2 or 3 years during COVID on all of the web education that we've been doing, so it's nice to be able to interact in person with all of you. No disclosures for this particular talk, and I wanted to start off with a case. I'm sure you have ones like this in your own practice. It was a 51-year-old man who was driving back to Houston from Louisiana when he started to have chest pain. And so he came into the emergency department, stuttering chest pain overnight. You can see a fairly bland-looking EKG, maybe some hyperacute T waves, myocardial injury, and was diagnosed with an NSTEMI. Was taken the next morning, one of those interesting cases where despite a relatively bland EKG, had a thrombotic occlusion of the RCA that was successfully stented. And as you can see, the challenge is what to do with this non-culprit lesion in the LAD. He's asymptomatic, his EF is normal, and no regional wall motion abnormalities. And as I've shown this case all around the world, people select any one of these various options over there. And I'm sure in your own practices, and if we polled everyone here in the room, we would also see heterogeneity of practice. So I'll return to this at the end and show you what I did, but talk a little bit in the interim about the goals and what are we doing. And I want to focus on these 5 things that might happen to those non-culprit lesions and think each one of them through. Of course, we don't anticipate the stents are going to be able to cure cancer, right? So all of the potential mechanisms of death that might happen that aren't cardiovascular, we're not going to be able to affect. And it's humbling to realize that those can be a large majority of the causes of death, even in cardiovascular trials. This is data from the IFR Sweetheart study that was published early this year, where 2/3 of death was actually not cardiovascular. Even if we focus just on cardiovascular death, multiple randomized trials, I'm showing you 6 here with over 12,000 patients, have shown that revascularization does not reduce cardiovascular death. And my slides have disappeared, but the implication for all of that then is that death, because we can't change cancer and we can't change cardiovascular death, is probably not a meaningful endpoint from trials. That stands in stark contrast to what we can achieve with spontaneous myocardial infarction, heart attacks, right? So again, looking at these 5 randomized trials, over 11,000 patients, we can see a significant reduction in MI when we revascularize lesions. It's not a high rate of MI, maybe 2.5% a year of unrevascularized lesions progress to MI, and PCI decreases that by maybe a third or something like that, and you can see the numbers needed to treat are somewhere between 20 and 40 patients over the next 3 to 5 years. What was interesting in some of our pooled analyses too is when you look at the clinical presentation, whether it be acute versus stable, there's actually not a significant interaction there, really indicating that most non-culprit lesions in patients who present with acute coronary syndrome are actually stable lesions, right? What about periprocedural infarcts? And this is an area where I think we still have a lot of work to do. And the reason I say that is that most periprocedural infarcts simply don't matter. And the reason is the data on the slide from the ischemia trial. Up in blue at the top are procedural infarcts. You can see that those were not related to death, unlike the spontaneous infarcts down at the bottom as highlighted in red. And actually spontaneous infarcts are about 2 or 3-fold more common anyway. So we should probably stop worrying about the troponin leaks that we see afterwards. Furthermore, think about this case. It's a patient who had an LAD STEMI, got the LAD stented. I measured FFR in the circumflex, it was 8.7. And then 8 months later, the patient came back with an NSTEMI in the RCA, and the RCA was quite normal at baseline. Should we say that this is a failure of FFR, right? I don't think so, right? Because I measured it in the circ, but the problem happened downstream in the right coronary artery. But yet, if you look in clinical trials, again, this is from the Flower MI trial, you can see that non-target events end up making the majority of future lesions. And so what that means, as I say here, is that there's a trade-off. You have less PCI, more target vessel MIs, but the event rates overall are quite modest. Finally, of course, we can make patients feel better with PCI. This is just a large, diverse number of definitions from these various trials, but no matter how you slice it, revascularization makes patients feel better. And sometimes people say, well, I could also reduce the amount of PCI, but in a way that's a bit of funny bookkeeping, Enron accounting, I call it. Enron, as you recall, was a firm from Houston who was fiddling the books a little bit. So if you simply look in the complete trial at the number of PCIs in the complete arm versus the culprit lesion only arm, you'd say, hey, it's lower. But that's, of course, because you discounted all of the initial revascularizations. But everybody got revascularized in the complete revascularization arm, right? So actually, when you tally up all the stents that were put in, it's tenfold higher when you have a complete revascularization strategy. So the trade-off is you're going to end up putting in more stents, but you'll reduce the rate of spontaneous MI and improve symptoms. So then it becomes a question of selection. And I'm going to talk in the next segment then about fractional flow reserve. And you might well ask the question, is this something that we want to be getting into in the acute infarct case? This is a paragraph from the Compare Acute trial that was published in the New England Journal of Medicine, highlighting that one of the patients in it, while they were making this non-culprit assessment, dissected the right coronary artery and the patient died in the hospital. However, as you look at the larger literature, that kind of thing is quite rare. These are 4 randomized trials of using FFR in acute coronary syndromes, looking at both wire-related injuries in this table as well as the effects of IV adenosine. And I think when you look at the global picture, while of course it might be interesting to focus on the 1 or 2 patients who have wire-related injuries, overall a general system of a signal of safety. Some of the more experienced seasoned cardiologists in the room will remember that actually IC adenosine was explored 15 or whatever years ago as a treatment for reperfusion injury, and so actually there's a large amount of data on using IC adenosine if that's your hyperemic drug of choice, over 1,000 subjects in 7 trials, and you can see here strong signals of safety. The FFR value itself is quite reasonably stable. These are 3 trials at the top where FFR was measured in the immediate setting, right when the patient presented with an acute coronary syndrome, and then brought back later for a second FFR assessment. And of course, there's always some test-retest variation. You can see that the numbers are bounce up and down a little bit, but on average, if you look across these studies, there are very small changes if they do happen, and only a tiny number of patients have any significant differences between them. The work in the lower right-hand part is some very nice animal work that actually Dr. Lee, who's one of the faculty members here, did, where he measured both FFR and IMR in the culprit and non-culprit vessel as they did microembolization, showing that, again, FFR in the non-culprit lesion is quite stable. What's fascinating when you look across all of the randomized trials of FFR and ACS is that only about 60% of these non-culprit vessels are FFR positive. That means that there's a large minority, 4 out of every 10 lesions are going to be FFR negative. And so what should we do with them? And I want to then speak to the Flower MI trial that came out last year. This was a study out of France looking at non-culprit lesions that were noted at the time of STEMI and compared 2 strategies, one using FFR guidance and the other using angiographic guidance, enrolled just over 1,000 subjects and looked at a combination of death, MI, and urgent PCI. And as you can see in the upper right, that net composite endpoint was no different between the 2 strategies. And some people have taken this to be then a negative trial against FFR, but I really want to turn it around and highlight, I think, 3 important takeaways from their data. The first is that operators were more willing to use FFR, right? When you look at the number of non-culprit lesions, it was higher in the FFR-guided group. Now, that shouldn't happen if you pick your lesions up front, right? But this might happen as I say, oh, we're in the FFR group. You know what? I'm going to go ahead and FFR that RCA. That's why you get a higher number of non-culprit lesions in the FFR-guided group. As we see with all FFR trials, FFR reduces the amount of PCI, right? Takes it down by 40%, because as I mentioned, only 60% of lesions are FFR positive. And interestingly enough, in this trial, about 15% of all non-culprit PCI, even in the FFR arm, was done without FFR guidance. So a large number of lesions that simply didn't follow the protocol. Furthermore, if you look at the data, you could flip it around. You can say, all right, there's no advantage to FFR for death or MI, but you know what? There's no disadvantage to it either. So if there's no difference in death, no difference in MI, no difference in late PCI, and if you look at the data at the top of the table in terms of anginal medications or CCS class, you'll see there's no difference in late angina. That means that you can reduce PCI by 40% and still have the same net clinical benefit. So I want to finish by going back to this case. As you recall, it was a gentleman who had an RCA thrombotic occlusion. Actually, in this case, at the end of it, before I took him off the table, I just quickly popped over and measured the FFR of 6.2 in the LAD. I decided to defer because the emergency department had done a CTA for pulmonary embolism, and so he had had a fair contrast load already that day. And so I brought him back 3 weeks later, and when I repeated it, so it was 6.2 on the day, 6.1 3 weeks later, so quite stable. Put a nice long IVUS guided stent in there and got it up to 8.5. And so this is the final slide, just emphasizing that there are these different strategies that we can use. We can stent them all, we can do FFR, which will probably have the same clinical outcomes but reduce stent use, or we could do nothing, in which case there's a slightly higher rate of angina and subsequent MI. Thank you so much.